So we get a dispatch call saying we have a person that's been shot in the chest. So we're going to arrive on scene to make sure the scene is safe. Nature of illness is going to be there. Number of patients, additional resources, and then considering C-spine would be my acronym SNAC. So as I arrive on scene, we're going to see if our scene is safe. I don't see any major threats for myself and my partner, so we're going to be okay. We're then going to identify the nature of illness. So nature of illness would be a gunshot wound coming up to this patient. And then the number of patients we have is one. Additional resources, we might need additional resources becomes a bigger issue, maybe internally. So I would not do it right now, but if we need it, we will. And then considering a C-spine, my partner would actually get towards the patient's neck and stabilize her spine. That way she doesn't have to roll her neck very much. So once we do that, I'm going to approach the patient. I'm going to identify a nature of illness, which would be a bullet wound. I would then see if she's conscious or not. So I'll go, hey ma'am, are you okay? Identify her nature of, see how level her consciousness is, would be the APFU scale. Then we would address the life-threatening illness. So it would be a major bleeding. So imagine there's a lot of blood here in the bullet wound. I would then get cut off all of her clothes to where I could see the extremity. We would then try to get that stopped by using dressing. This is the best dressing I could find at Walgreens. So I'm going to put it right here, right in the center of the chest where the bullet wound is. And then this is actually supposed to help her from a possible pneumothorax. So what we're going to do is we're going to hold it in place and tape it to where she might be able to function better. And then you want to put it on this side as well, not the other side completely. That way, if she does have a pneumothorax, this could save her life. Okay, so now that we addressed the major life threats, we're going to identify the ABCs. So it will be airway, breathing, circulation. If her airway's not clear all the way, I would do a chin lift, or a jaw thrust really. And then we would open her jaw up to where it's clear. Assess her breathing with the stethoscope, make sure she has adequate breathing on both sides of her lungs, as well as her back as well, if we can. Identifying circulation as well would be on our distal pupils. Distal, yeah, the distally over here. And once we do that for 5 seconds, if it's a weak rapid pulse, this is probably not a good sign. But if she is having patent breathing, we would also give her 15 liters of oxygen via non-rebreather mask. Once we figure that out, we're going to identify her GCS scale, which is her Glasgow-Coma scale. So depending on that, we would address the priority of the patient, and we would start to transport her as soon as possible. So me and my partner would get a backboard, and we would try to see if we can, once we get that figured out, we're gonna, once my partner is getting the backboard really, I'm then gonna address from head to toe on the patient. So what we're gonna do is, I'm gonna come over here and we're gonna assess the scalp, make sure if there's any type of major lacerations or abrasions in the scalp, make sure she's okay with her neck as well if there's no pain. Open her mouth to see if she has any broken teeth or anything like that. Make sure you get a light to detect the pearl, which would be her pupils are equally round and reactive to light. If that's good, that's a plus. I would then go down to her shoulders, make sure if her shoulders are okay, make sure there's no tenderness or anything like that. We would then go down to her chest, make sure if there's no major rib fractures. We would then go to the abdomen, do each quadrant, see if there's any tenderness from the patient or if she's reacting to the pain. If not, that's a plus as well. Go down to the hips as well, see if there's any hip fractures, noticing if the patient reacts to anything. Go down to the legs and knees, make sure everything's good to go. Once we do that to all of her lower extremities as well, and we make sure if she's not any tenderness, bruising, or anything like that, we're going down to feet. Make sure if she feels my feet, ask her, ma'am, can you feel my feet? If she would say yes or no, I would then see if she can kick her feet back and forth, so it'll be extended and flexion. That's a plus as well. Once we figure that out, we're then gonna go and check her hands as well. Ma'am, can you squeeze my hand for me? Can you let go? Can you tell me what side of my hand am I holding? Once she tells me additional, if there's any additional problems, we would address that. Finally, once we get that figured out, I would also get a sample history as best I can, which would be any allergies, medications, anything to make it better or worse, possibly her last meal that she ate to affect any type of medications that could happen to her, or she might have any complications for like diabetic or any type of issue like that. And then kind of the events leading up to it as well. So that way we can get a better baseline of what happened. Once we do that, I would then give my partner would eventually come back with that backboard, and we would slowly, I would make sure her spine is okay, and we would try to roll her over as slowly as possible, the log roll, and we would slowly see if she's okay, assess her back. If she's okay, no major pain, ma'am, she would address it to me. Then my partner would be on the opposite side of where I am right here. We would get a backboard. We would scooch her into the backboard, like so. And then we would probably prompt her up into the gurney to where we would transfer her to possibly CRMC or other major trauma hospital. And that's going to conclude my assessment.